Hello everyone, greetings from Pandit Hospital, Dr. Hrishikesh Pandit. Today we are going to demonstrate to you a step-by-step procedure of laparoscopic radical hysterectomy type C1, that is nerve sparing type of radical hysterectomy in a case of stage 1B2 cancer cervix where cervical growth is of 2.8 cm size. We have inserted two side ports on the left side for the surgeon and one right-sided port for the assistant. Kindly make a note that we have put Schauter's stitch, that is, a stitch is put vaginally over the tumor so as to avoid the tumor cells from spilling into the peritoneum when the vault is being opened. Following oncological principles, no uterine manipulator or myoma screw is being used for this case. First step, we start with bladder dissection. We are using a harmonic scalpel. Incision is made from left round ligament till the right round ligament. This is a crucial step in deciding the operability of the case. If dissection of the bladder can be performed smoothly, it indicates that it is not involved and therefore proves the case to be operable. We start dissecting between two lateralmost points on the round ligament. The assistant is retracting the UV fold perpendicularly and cranially so as to create bubbles or champagne effect by allowing carbon dioxide to enter into the tissue and create planes. The surgeon also gives a counter traction to create more bubbles. Bubbles are then pushed and strands are cut and bladder is dissected off the cervix. Respect is given to each capillary to prevent bleeding and soiling of the field. Bladder is gently pushed down caudally so as to expose at least 2 cm of vagina to get an adequate tumor-free margin of specimen. Here we are dissecting the bladder pillars, that are bladder strands above the uterine artery. Next step is opening of retroperitoneum by oncological or lateral approach and developing of all 6 avascular spaces. We start with opening the peritoneum by giving an incision from right round ligament till the right IP ligament as close to the lateral pelvic wall as possible. Important is to note that while doing this, the surgeon shifts the traction of left hand from round ligament to IP ligament. Incision is continued till the sacral promontory. Sharp and blunt dissection is used to dissect the loose areolar tissue. The first structure that we are going to visualize on the lateral pelvic wall is the external iliac artery and medially the ureter. The space between the external iliac artery and the ureter is the lateral pararectal space, also known as the Laparoscopic space. Dissection is continued in this space in order to expose the external iliac vein caudal to its corresponding artery and then the internal iliac artery and vein. Careful dissection is done in this space so as to prevent any injury to the great vessels lying along the lateral pelvic wall. We continue to dissect along the internal iliac artery. Here we can see the internal iliac artery giving off its first medial branch, that is the uterine artery, which is identified by its characteristic feature of blue color and tortuous nature. We can also see the second branch given by the internal iliac artery, that is superior vesical artery. Uterine artery divides the anterior paravesical space and the posterior pararectal space from each other. Here we are coagulating and cutting the right round ligament close to the lateral pelvic wall. Internal iliac artery continues as the obliterated umbilical artery, which is seen as a streak-wide structure which divides the paravesical space into medial and lateral paravesical spaces. Here we are dissecting into the Yabuki space, which is also known as the fourth space. It is a retroperitoneal space between the ureter and the vesico-uterine ligament. It contains pelvic splanchnic nerves supplying the bladder. It is important to conserve these fibers during nerve-sparing type of radical hysterectomy. Next step is lateralization of ureter, which is done from sacral promontory till level of uterine artery and further along the ureteric tunnel till the ureter enters into the bladder. Here we are creating space between ureter and uterine artery by blunt and sharp dissection. Ureter carries its own vascularity in a sheath encasing it known as the Valdeir's fascia. Thus, while dissecting, one should take care to preserve the vascularity of the ureter. The assistant is retracting the uterine artery and we can see the ureter crossing under it, known as the water under the bridge. Here we can see the tunnel of Wertheim's or the ureteric tunnel, which is formed by the anterior and posterior cervicovesical ligament, which carries veins with it. We are coagulating and cutting the anterior cervicovesical ligament, thereby deroofing the ureteric tunnel. Now we can see the ureter finally entering into the bladder. Improper handling of tissues at this step can lead to tearing of blood vessel and soiling of entire operative field. We can clearly visualize the importance of adequate traction and counter traction at this point, both by the surgeon and the assistant. It is important to know the limit of dissection of ureteric tunnel so as not to enter into the bladder. Finally, the entire uterine artery is being skeletonized and ureter is being delineated from sacral promontory till its entry into the bladder. Here we can see the intact uterine artery and the entire ureter dissected till its entry into the bladder on the right side. We repeat the similar steps on left side to open the retroperitoneum. First we dissect between the external iliac artery and the ureter. On the left side, the ureter crosses over the common iliac artery, whereas on the right side it crosses over the external iliac artery. Ureter divides the pararectal space into medial and lateral pararectal spaces. Medial pararectal space is also known as Okabayashi space. This is important because it carries hypogastric nerve and inferior hypogastric plexus, which is important for voiding of bladder and rectum and also for sexual function. Now we dissect along the internal iliac artery to see it giving off its first branch, that is the uterine artery. Make a note that uterine vein runs caudal and along the uterine artery. Uterine artery and deep uterine vein form a fork and ureter is sandwiched between the two. Here we are lifting the uterine artery and creating space between the uterine artery and the ureter by using divergent forces so as to avoid ureteric injury when we will be coagulating and cutting the uterine artery at its origin. Here we can see the uterine artery giving branch to the ureter, that is ureteric branch of uterine artery. We continue to skeletonize the uterine artery. The vascularity of the uterus is maintained till the entire pelvic ureter is dissected, because if we have to decide the case to be inoperable when we cannot dissect the entire ureter, in that case maintaining the entire vascularity of the uterus is helpful in giving radiation to a cancer cervix patient, as radiation acts better with intact vascularity. Next, now we are holding the uterine artery and gently pulling it up in upward direction, and a window is created underneath. Short bursts of cutting currents are used. Uterine artery retracted by the assistant. We are dissecting on the lateral side of the bladder pillar to skeletonize the vesico-uterine ligament along with its containing vessels. The vesico-uterine ligament is then gradually coagulated and cut in small sections. Thereby, the left ureteric tunnel dissection is done. Now we are dissecting the ureter of its broad ligament attachment. We can see the entire ureter dissected till the bladder with intact left uterine artery from its origin. Now we will open the recto-vaginal space. It contains Denonville's fascia, which is a two-layered fascia between the rectum and the vagina. Assistant is giving tenting traction on the rectum so as to create bubbles and help in dissection. This step is important to remove an adequate tumor-free posterior margin of vagina. Now we are retracting the obliterated umbilical artery medially, so we can dissect into the lateral paravesical space. Here we can see the obturator fossa with obturator nerve and vessels. Also we can see the left-sided corona mortis. Similarly on the right side, the obliterated umbilical artery is retracted medially, and we dissect in the lateral paravesical space to see the obturator nerve and vessels and the right-sided corona mortis. Next we create a window in the broad ligament and coagulate and cut the IP ligament. Here we are using Covidian ligashore for coagulation and cutting of the IP ligament and also to cut the broad ligament. Now we are coagulating and cutting the uterine artery at its origin. We are dissecting medial to the ureter in the medial pararectal space, also known as the Okabayashi space, which contains the hypogastric nerve and the inferior hypogastric plexus. These are to be preserved in nerve sparing type of radical hysterectomy. Here we can see the inferior vesical vein draining into the deep uterine vein. Inferior vesical vein is the limit of dissection of anterior parametrium. We need not dissect beyond it. Now we move on to the another essential component of radical hysterectomy, that is parametrectomy, without which surgical treatment of cancer cervix is incomplete. When taking out the parametrium, one should not go very much lateral on the ureter side, as we may compromise the inferior hypogastric plexus. Similarly, on the right-sided IP ligament is coagulated and cut, and right-sided uterine at origin is coagulated and cut, and reversed and flipped onto the ureter. This is known as the Barrett's maneuver, which is important for completeness of parametrectomy. In nerve-sparing type of radical hysterectomy, the deep uterine vein is taken medial to the ureter. If we take the deep uterine vein lateral to ureter, it is known as non-nerve sparing type of radical hysterectomy. After adequate parametrectomy, next step is opening of vault. At least up to 2 cm of vagina is to be excised for adequate tumor-free margin of specimen. After the vault is opened, specimen is removed vaginally. Now we move on to the second part of the surgery, that is bilateral pelvic lymph node dissection. The lateral limit of dissection is the genitofemoral nerve, which is lying on the psoas muscle lateral to the external iliac artery. Short bursts of cutting currents are given. Care is taken to prevent any injury to the great vessels lying on the lateral pelvic wall. The anterior limit of dissection is the deep circumflex iliac vessels. The entire lymphatic tissue is to be dissected and removed en bloc. Care is to be taken to prevent any capillary bleed which will spoil the entire surgical field. While dissecting the obturator group of lymph nodes, care is to be taken to prevent injury to the obturator nerve and vessels lying in the obturator fossa. Here we can see the white streak structure, that is the obturator nerve, along with its vessels. The medial limit of dissection is the obliterated umbilical artery, and the caudal limit of dissection is the obturator nerve. We need not dissect beyond the obturator nerve. We can see the obturator artery and the obturator nerve here. Here we can see the pelvic bone laterally. Below it is the obturator internus muscle. Entire lymphatic tissue removed en bloc. We repeat the similar steps on the left side. Here we can see the ureter crossing over the common iliac artery on the left side. We are dissecting the external iliac group of lymph nodes with millimeter by millimeter dissection, preventing any injury to the external iliac vessel. The assistant guards the ureter. We need not dissect beyond the genitofemoral nerve. Care is to be taken to prevent any damage to the genitofemoral nerve, as it will then cause numbness along the anterior thigh and the labia. Short burst of cutting currents are given. Blunt and sharp dissection is used. We need not send the right and the left pelvic lymph nodes separately for histopathological examination, as if any of the lymph nodes come positive, there is no change in the treatment protocol further. We can see the obturator nerve and vessels in the obturator fossa. We can see the corona mortis, which is an anastomosis between the external iliac vein and the internal iliac vein or the obturator vein. Care is to be taken to prevent any damage to obturator nerve, which will hamper the motor function of adductors of the thigh. Entire lymphatic tissue removed en bloc. And sent for histopathological examination. Specimen removed vaginally. Next step is closure of the vault, which is done using Vicryl number 1 round body. It is always done from anterior to posterior, that is from high risk to low risk area, so as to prevent the needle from puncturing into the bladder. Vault is closed in a continuous manner. After closure of the vault, hemostasis is ensured. Here we can see all the anatomical structures clearly: the obturator nerve, obturator artery, internal iliac vein, corona mortis, external iliac vein, pelvic bone, obturator internus muscle. We can see the obturator nerve enters the pelvis in between the external iliac vein and the internal iliac vein. Similarly, on retracting the obliterated umbilical artery, medially we can see all the anatomical structures of the right side. Here we can see the entire ureter dissected from sacral promontory up to its entry into the bladder with conserved vascularity. Here we can see the bifurcation of common iliac into external and internal iliac, and the peristaltic movements of ureter can be visualized. This is the final picture. Here we can see the final specimen with more than 2 cm tumor-free margin of vagina. The specimen with adequate parametrial dissection. Uterine arteries taken at origin. Thank you. Hope you enjoyed.
Goodbye.